All right, can y'all see my screen and everything?
Yes.
Okay, perfect. So my name is Johnny. I'm the director of outreach here at Rain. And pretty much what we do here at Rain is we empower people living with or without HIV to live a healthier and more stigma-free lifestyle. Um, and that encompass a host of different things. A lot of the things that we try to tackle is the social support issues or the essential support services. What we have learned in our day, and you're going to kind of see some of this in the presentation today, is that while our main goal is to get our clients to achieve viral suppression, um, we know now today that we have to address the other barriers first before we're able to kind of achieve and maintain a client being viral suppressed or viral suppression. Um, so we have a youth-centric program, and this program is geared towards the youth. It's called EPI, and it starts at age 16 and go all the way up to age 24. And the reason why we got this particular program is because what we understand is that we can no longer group the HIV community together as one, because the youth actually go through unique barriers and different things that needs to be addressed in their situations. So what this presentation here today, it kind of talks about those unique barriers as it applies to the youth. Not saying that some of these barriers doesn't apply to our adults, but they're a little bit more prominent in the youth as well. Doesn't this take you back to your high school and college days? So the presentation is called "A Day in the Life of Our Youth." So um, I want to just do one of these. I'm not really sure who's all in the room today, but I kind of wanted to kind of get a little bit of a feel of who's in the room, so we can kind of break this case down together, and then we can kind of talk about it as I go through the presentation. Okay. So this will require some participation from you guys, if you don't mind. So this is a case study that I want to talk to you guys about. This is a youth. Anybody under the age of 24 is to be still considered as youth. So Eric is a 22-year-old MSM, man that have sex with men living with HIV. He comes into the clinic and complains of an STI. He works part-time at a local restaurant during the day and at the bar some evenings. He usually hooks up with individuals from Jack and Grinder, and those are two different hookup apps that is prominent in the LGBT community. He is not on art and is scared to start because of commercials and ads on Facebook saying pharmaceutical companies are being sued. So what ART stands for is anti-retro um, treatment, and what that does is it helps regulate HIV in the body to and bring it down to levels to where it's actually undetectable. So I'm going to ask you a couple of questions, and I want you guys to kind of answer it. I may help a little bit, and I may not. If it take too much time, so you guys kind of let me know what you think would be the best route to go. So, what are some steps that you would take to further assist what Eric may need in terms of his HIV treatment?
I would ask more questions about what specifically are his fears around medication,
Okay.
and kind of what information has he seen.
Okay, perfect. Anyone else?
Yes, I would like to work with Eric to uh, see that his health practices in terms of diet and others are that he's eating healthy and not just bar food to try to help his body be better able to resist not only the HIV or whatever or the sexually transmitted infections, but to, to help him resist any diseases that will that will weaken his body.
I love it. That was one of the good answers. Is this one of the best answers I've heard in a while? What we know now today is HIV treating HIV is not just about medicine. It's a holistic approach. So eating correctly, eating healthy also affects those numbers. So that was a good observation, Miss Sarah. Anybody else want to take a stab at this last question or this first question? Okay, it's fine. We can move on. What message would you give him around risk and prevention of STDs and STIs and HIV? One of the things that I would recommend is that, hey, one of the things that I want to empower you to do, and I'm glad that you came in today, is to kind of talk about your sexual health. A lot of times people don't even get to this point. And this is a really big step. So I would want to empower him and let him know that you're definitely doing the right thing. One thing, one of the key things in being a healthy sexual is knowing when, where, and how to go and get tested, and or access PrEP and or TAS, which is treatment as prevention. So if a doctor prescribed art, what would you tell him about taking his medication? Side effects and adherence. Anybody want to take a stab at it?
I think Sarah talked about eating a healthy diet and making sure he gets holistic sleep and all that, but also taking the medication regularly as prescribed, or else it's not going to work.
That is correct. So we want to make sure that it is not only important for it to be prescribed to him, but to know that he has to take it or needs to be taking it every single day to ensure that the right levels are in the body to suppress the HIV virus and bring up those CD4 counts. And the last question that I have for you today is what are ways that you can assist him with retention and care?
I think when you mentioned empowering him, but supporting him and keeping lines of communication and building a trusting relationship with him.
That is the perfect answer, and that's one of the things that we want to try to support, especially our providers, to let them know that it's not just about a transactional relationship. They need to know that that you are in their corner, and that is the one way that is one big step in how we build retention and care. Just skipping over the case studies. All right, so addressing barriers. So let's start talking about some barriers, right? The first one we're going to kind of tackle a little bit is homelessness. Can anybody kind of when you see this word, especially as it relates to the youth, can anybody kind of think of anything that come to their mind when they think about homelessness?
I think of stigma and how if a youth is outed um, or if their parents aren't accepting, that they aren't going to have a good home. And so we'll have to leave or choose to leave or, yeah.
Okay. Okay. All right. I'm going to move on to the next one. So that is one barrier. We also have mental health. Anybody want to take a stab at, or not even take a stab at, but kind of tell me what they think about or what comes to the mind when they see the word mental health, especially as it relates to our youth?
Playing a little bit off what Elizabeth said, um, acceptance,
Mm-hmm.
lack of stigma and shame,
Mm-hmm.
and having a solid support system,
Right.
access to
Perfect.
care.
Perfect.
I also know that mental health around youth has been on the rise um, during the pandemic and in general.
Yep. And we already kind of talked about stigma. So I'm not even going to ask you guys about that because that kind of came up a couple of times already. So with stigma is one of the biggest ones that we also face. And last but not least, peer and family influences. That is a big one and one that we still find very hard to kind of address because it's so embedded in who we are as people. especially in our youth. All right, so before we get into tackling those barriers one by one, I wanted to kind of give you a picture of what the healthcare continuum looks like, the HIV healthcare continuum. So we break these up into 5 pillars. The first pillar is at the very top and is diagnosed with HIV. That is the point of entry of that is the point of entry um, when you're starting your journey out in the HIV healthcare continuum. We move along to link to care. So they first got diagnosed, we have to connect them to a doctor and or a medical provider to start prescribing medicine. So we linking them to care. Linking to care also means being attached to a case manager or a youth navigator or a peer navigator. Those are also ways to be into care because there are often times where a person is diagnosed and it may take them 3 to 4 to 5, maybe even 6 months before they're able to kind of go see a doctor and or be prescribed. But if they're getting that peer support or that case manager or their peer navigation, they're still linked into care because there's more buy-in there, right? There's that seed is being planted, so they know that they have access to go get what they need, and so they're able to kind of walk that journey. That peer navigator, that youth navigator, the peer retention specialist, the case manager is able to kind of help them guide them to where they need to be, because we can't obviously force people to take anything, right? So we want to make sure that somebody's walking in the fire with them. um, that also go hand in hand with engage and retain and care. So that's what Elizabeth was talking about earlier, that building that relationship with the client, that building that rapport with the client, making sure that they know that you are their person, because that is one of the most important things. As we start tackling stigma, everybody needs somebody to go through something. You know what I mean? If we go through things by ourselves, it's kind of hard to kind of come out on the other end. So even if that person can't do nothing for you, just a good talking piece to bounce things off of, um, is a form of walking on nails with that client. Um, so they appreciate that a lot as well. Then we get to prescribe therapy, antiretroviral therapy. Um, so that is again a key component there, right? We want to make sure that people are or individuals are given the right tools to be viral suppressed. So that is a big step there as well. And then but last but not least, and the ultimate goal is to achieve viral suppression. Um, that is one of the things that we want to capture, we want to get to, we want to monitor, we want to support, and we want to report back so that we know that we're gaining a control over this epidemic. So I gave you those pillars, I gave you those barriers. I want to go ahead and start breaking things down, okay, in regards to why this is important for the youth in particular. So I'm going to start off at that first pillar, which is diagnosed with HIV. So the diagnosis with HIV is the pillar, peer and family support is the barrier. So when youth are under the age of 18, their parents must be notified when they test positive. Half of the time, the youth does not have not even had the conversation with their parents about they are having sex or anticipating in sex at that particular moment. So that becomes an issue. Not only are there um, having to report to their parents that they're HIV positive. But if they're in the LGBT community, that's also been addressed at that time frame as well. Who are you having sex with? How are you having sex? So a lot of conversations, a lot of pillars are being peeled off at one time, and that can be a little overwhelming. Right? Their power has been taken away from them. Because they're having to address so many things at once, and their parents want that answer right now. You know what I mean? And they feel powerless at that particular moment. So why go get tested? That's the can of worms I don't even want to open up. I identify with this the most was because when I was diagnosed at the age of 13. And I was in a hospital, and those layers had to be peeled off right then and there at one time, at the same time. My sexuality had to be addressed. The fact that I am having sex or sexually active has to be addressed. And the fact that I am positive has to be addressed as well. That is a complex conversation. Um, and 14, 15, 16 year olds, it needed to be broken up in parts, and a lot of times we're not giving that grace because it's happening at one time. It's happening right now. We're in this moment. We're live in this moment. We're in the thick and the filth of it. And I need answers as a parent, right? So I get it. The other caveat to this, say they over the age of 18, and no, they don't have to report back to their parents when they go and get tested and things like that, but they're still on their parents' insurance. Anytime that a person is on their parents' insurance and they go into a doctor, they are going in for different things. Most of the time, those things appear on um the statement that is being mailed back to the parents for the insurance because they're paying the bill. They're the primary card holder. So a lot of questions are starting to be asked then. Hey, what's going on? I see that you are on prep. I see that you went and got tested. I see that you got treated for this, and things like that. We have a couple of workarounds now, but for the longest time, that was a big issue and a big barrier to getting individuals in care without their parents knowing, because they wasn't able and ready to have the conversation. Not to mention, disclosure is more difficult for youth due to their age and their early stages of the brain development and level of emotional maturity. Right. One of the things that I have been talking to people about actually for within the last year, and I'm going to venture off and talk about the whole LGBT community, is there are not enough family support programs to help individuals that are in the LGBT community to kind of guide them on how to address different things with an LGBT child. Right, we have all of these things for the youth and the LGBT youth, but the parents need support as well. How do I address these issues? How do I go about saying this and things like that? Because it's a different world for not just them, but for both of them. I think that is important that we venture out and connect with those support groups. There's a support group here in Charlotte, North Carolina called P Flags. That is actually underutilized. And what they do is they provide a support group for parents that have LGBT children and help guide them with conversations and bounce things off with each other and things like that. No, there's no rule book in being a parent, and there's damn sure no rule book in being a LGBT parent. You have to kind of face things as they come, and sometimes it's nice to kind of have people to kind of go to and bounce things off of. Um, Another conversation I was just having with one of my trans clients was they came to the understanding and idea the grief process, right? So I grew up with um, my son for 16 years. My son died and birthed a trans woman. There is a grieving process that also needs to go with that as well. And sometimes we also have to give our parents grace and time to adjust that portion as well. So I also talk to my clients and my youth about the adjustment period. It took you 16 years to feel comfortable with yourself. It's going to take other people, your outside, externally, to feel comfortable with this change. You know what I mean? And it's not a good thing. It's not a bad thing. It's just we have to adjust to different things. It takes time for a chameleon to readjust to their environment. It takes time for we have to readjust different things, and sometimes we have to give each other grace. You know, that ain't everybody's situation, um, but it comes up in conversation a lot. HIV in high school. Uh, you tell your best friend who you think that's your best friend, and before you know it, the whole school kind of knows, and it just spreads like wildfire. So we try to help navigate those conversations and let people know that you do not have to disclose this information to your, you don't have to, find your circle, pick your friends, and things like that, and be careful with that information because that is your identity now. And that's part of your identity now. I'm sorry. So you need to be careful with that information. Be careful with who you extend yourself to. And sometimes it's hard for a teenager to actually grasp that and understand that. One of the big things that we've also seen is that when youth are born with HIV, 9 times out of 10, they are informed around the average age of 13. Is what we see. Um, these create unique barriers because for 13 years they have been lied to about why they've been taking this pill and or medicine. What's been going on with me? Why have not been notified about this sooner? So there is a trust that has been broken at that particular point, and we have to go in and try to address and make understanding of why that was said and why that was done to protect the youth and things like that. I'm not saying that is right. I'm not saying that that's the best way to do it. But we want to make sure that that the youth can regain their trust with their parents or any other individual that was a part of that conversation surrounding their their status. So the next barrier we're going to talk about is stigma. It goes hand in hand with the peer and family support, being judged by their community, peer, and or family. A lot of times people don't even want to be seen going into a clinic to get tested for anything. So that creates unique barriers. Who's going to see me walk into this building? If I do find out if my results come back positive, who's on the outside that can hear or that a lot of that comes out as well. Um, there something that somebody said. I'm not remembering who said it on the call a little bit earlier was that shame. What we call that internalized stigma. And what we know now is that internalized stigma, I feel like, is even worse than external stigma because it is that shame component. It is how you feel about self. And the lack of knowledge can make you feel like, you know, I don't need to be, or I don't, I would rather not know what's going on within me because it's something, if I know, I would have to address it. And so that stigma portion kind of comes along with that as well. So we call it internalized stigma. We think that does a lot more damage than external stigma because again, it's how you think about self. Mental health, again, that comes up a lot we're still at that first pillar, which is diagnosis for HIV. That comes up a lot in regards to, again, they're not, um, they may have mental health issues that has not been addressed yet, which will prevent them from being or going to get tested. A lot of times what we've seen is some mental health things that have not been assessed and or addressed yet comes out when they are diagnosed. There's a that something traumatic just take place, so some of those things start surfacing, um, and they aren't able to cope with their diagnosis and not willing to seek therapy. We see that as well. Again, we're going back to that first one, which is homelessness. A lot of our youth under the age of 18 can't and will not qualify for the housing programs. They've gone through. They've had to address the fact that they are LGBT. They have to affect the fact that address the fact that they are positive. Um, we have seen youth where they're getting kicked out of their homes. They're getting kicked out of their homes. Not qualifying for these programs. They are couch surfacing. And couch surfacing does not meet the HUD definition of homelessness. And what that means is if you are sleeping on your friend's couch last night, then the HUD does not define you as being homeless. So again, that knocks you out of the qualification as well. So those are things that we're still fighting and still trying to address and still trying to change that systematically because um, this couch that I'm sleeping on today may not be there tomorrow because things are so fickle. So now we're going to go to the next barrier, or I'm sorry, pillar, which is linked to care. So again, that peer and family support, having to hide their diagnosis, not having no support network. Um, we see this so much. Um, they feel like they can't tell anybody. They're going through this alone. Um, I often tell people that HIV is more of a mental disease than it is a physical disease. Your body can last a long time without you even knowing that you have HIV. But once you find that information out, your mental takes over, and your mental, I feel like, controls your body. So when you start thinking bad and feeling bad, your body is reacting to that. Um, so not having a support team, a support network, a care team to kind of help you through those bad times affects you being linked to care. A lot of times people don't want to go to the doctor's office by themselves. Um, they don't want to address those issues by themselves. And they have to trust somebody in order to kind of go with them, right? And so sometimes that trust component is just not easily gained and not easily accessible to people, especially the youth. Um, so if I don't have nobody to go with me, I'm probably not going to go to my doctor's appointment. Sometimes there can also be me not having a ride to my doctor's appointment or to my case manager meeting, peer support meeting. Um, that goes hand in hand with not having that support network. We talk about stigmas. Again, youth not being comfortable with attending clinics and being afraid of who they would see, who they would come across, who else is going to this clinic for a different reason. Having to hide having to hide their pill bottles or their appointment papers. Typically when they come here and sign up for paperwork, we send them out with paperwork so they can kind of keep and kind of know different things. Um, that also can be a barrier and a challenge because they don't want nobody to kind of see that. Oftentimes we see these papers end up in the trash, ripped up and things like that because they cannot go out with those papers and have no secure place to kind of put it without it being seen or somebody actually somebody actually stumbling across them. Um, the next portion would be mental health. Providers aren't aware of client barriers or mental state. So oftentimes, when a person is diagnosed, we try to connect them with an infectious disease expert or a specialist. Sometimes there may be a lack in accessing that client's medical records. So if there was a mental health diagnosis or things like that, that provider may not find out at that first point of entry, right? What we also know is that we do have medicines that treat HIV that does affect the mental health as well. It does affect depression. It brings out depression as well. And if somebody's already battling depression, um, you know, that medicine can come in and kind of enhance that, right? So we want to make sure that we have um, and can get the client's medical records so that the client can have a holistic view, or the provider can have a holistic view of the client's medical history. Also, um, and I'm sure some of you guys have seen this, is youth have this idea that they are invincible, right? Um, and why this right here can be very difficult to kind of talk about because, like I said, HIV can exist in the body for a long time without us even knowing that is there. A lot of times, people can be on medicine for a long time or be off medicine for a long time, and they not see any physical change or damage to their body because they're not seeing a doctor either, right? And so, because I don't feel different, I'm good. I'm fine. I feel okay. I can go out into the world and be me and live how I want to live. Um, Not understanding the fact that their body is working 10 times harder to maintain them feeling good, right? Their body is working 10 times harder to maintain them looking good and being healthy. One of the things I like to tell people a lot, an analogy that I've heard and kind of stuck with, is your organs in your body is like a house. And what HIV does is it goes in and turn on every light in your house. Every organ is working hard to maintain your HIV, right? What the medicine does is it come in and turn off those lights and give those lights a rest, right? Because at the end of the month you're gonna get a high light bill because you've been running power all every day, all day, all night. There's no rest there. So that's one of the good example I like to try to or a visual I like to try to get the youth to understand as it relates to them and HIV and how they may feel. While you may feel good, that house ain't don't have no physical damage. The house still feels good. It still feels warm and cozy inside. It's still a house, right? But again, the wires and everything that's providing power to the house is working 10 times harder to maintain light. What we also see, but that becomes a barrier as it relates to linked to care is survivor relationships. A lot of our youth get into survivor relationships because they don't have anywhere to go, um, and engage in survival sex to ensure that they have somewhere to sleep at night, to ensure they have some food they can kind of get access to at the time frame as well. So those are barriers that we also see because that hinders them from coming into an office or coming into seeing a medical provider. The next pillar we have is engage slash retain and care. So what we see now, and what we also notice, and I'm sorry that was so small, is the lack of support from all areas, right? Um, a lot of our programs, I'm actually going to hold that, and I'm going to come back to what I was about to say. So the lack of support from all areas. Again, if that client or patient, youth, do not have access to transportation, do not have access to um, talking to people and regarding their status, they're not going to be engaged in their care. If they're not a part of their care plan, they're not going to be engaged in care. If they're going into a doctor's office and the doctor's telling them what they're going to do and what they have to do, um, and there's no buy-in, they're not going to stay engaged in their particular in their care. It is important that we try to send most of our youth to the doctor's appointments with a youth navigator to kind of help bring out some of those conversations, so the youth can kind of feel like they again have the youth will feel like that they have buy-in in their own healthcare. Um, Becoming HIV positive in a young age is an adult. I feel like is bringing a teenager in an adult world. It's like a 16-year-old or 15-year-old having to go out, get a house, pay rent, understand finance, understand how to maintain their bills, understanding that they can't go out every night, understanding that the fact that they have to provide food on their table. But that's pretty much what the youth is walking into. Because again, they have to learn really fast how to navigate the healthcare continuum, the HIV healthcare continuum, how to talk to their medical provider, things that they wasn't brought up with learning. They have to learn that really really quick, really really fast. And again, the lack of support from that is only going to make that worse. So we try to kind of counteract that on the front end. Stigma. Again, reinforcing of taking medication. Sometimes the internalized stigma get in the way of taking this medication. I don't want to be reminded that I have HIV every single day. Sometimes I need a break. I can't take this pill today. I don't even want to see this pill. I'd rather go out and do something else. You know, um, so addressing those stigmas is really really important. Um, Also, working with doctors who are not sex positive. You don't know how many times we've had to switch and change doctors because a client, a youth is feeling condemned at the fact that they're still having sex. Um, that is their youth reality at that particular moment, and you condemning them for having sex, especially after it's been that boat has already sailed, is not going to be conducive to the success of that particular youth. So giving them other tools, giving them other tools to be safe, to be secure. I'm giving them other tools and knowledge on how to maintain, again, maintain viral suppression or get to that viral suppression state. Talk about other STDs and STIs. Um, Again, a lot of times we know that youth are not able to hold conversations with the providers about having an STI. They're embarrassed. A lot of these doctors and or physicians take on the fatherly role when it comes down to their youth, right? I've seen it. I've had a doctor for a couple of years that have done that to me, where I'm nervous because I feel like I'm talking to a fatherly figure or a motherly figure, and don't want to disclose some of that information. And it took me a while to kind of get over that. And some youth never get over that. I remember I used to go to the doctors with my grandmother, who was well in her 50s. My grandmother used to smoke cigarettes, right? But whenever we get into the doctor's office, the doctor's office asks, "Do you smoke cigarettes?" I ain't smoked cigarettes in 20 years, and she just had a cigarette right before we walked into this doctor's office. Clearly, the doctor can smell it because I can smell it, but but that she just didn't feel comfortable telling him that information, you know. Um, so the youth also faces that as well. Again, mental health might not allow them to prioritize their health. So if if they're battling different mental health things or diagnoses and things like that that has not been addressed, um, that may prevent them from engaging and being retained in care. We've seen that here at the office where somebody may have been linked to care, started out very well, and but their mental health was not being addressed and or maintained. So that just trickled over to the HIV healthcare continuum. That fell off as well because the mental health was not addressed. That's when I talk about essential support services. Um, Also, the youth jeopardize their health due to housing instability. Um, so if I'm walking or trying to find somewhere to sleep all night, I don't know how I'm going to get up early in the morning to make the doctor's appointment. That is a barrier, something that we have to we have to address. So that what we know now is that if we can secure or try to secure and help secure housing for that client, there's a better chance that they're going to engage and stay retained in care. So going to this next pillar, which is prescribed therapy. Um, I haven't run into this in a while, but it has come up. Some family belief systems can hinder clients from taking their medication. For example, the herbs and remedies and the silver capsules. Sometimes like their religious beliefs, they are not going to let their child take the HIV medication. That becomes a barrier. Again, we cannot force a pill down somebody's throat. And if their parents or their legal guardians is giving a hard no, we have to kind of take other routes, kind of ensure that particular youth is being taken care of and being safe. Um, Also, they're afraid to take their medication in certain environments. I remember I was diagnosed at the age of 13. I didn't do overnight stays at anybody's house because of this reason. I didn't feel like having to explain why I'm taking this pill every single night. Um, I took my medicine at nighttime. So to avoid that all around, from the age of 13 to 18, I never spent the night over nobody's house. And that is you teenagers things. Those are things that you do. Um, but I just never ever wanted to. I didn't want to open those can of worms. And also, um, sometimes if they are spending the night over somebody's house, they may forget to take their medication. They may forget to bring it, things like that. If um, they're on I remember we used to go to this senior trip, right? So there's 3 or 4 days of out, and you're being housed with other people at your school, or in a room. There's not enough privacy to kind of take your medication without being bothered. So I didn't take the medication with me. So I went 4 days without taking my medication because I wanted to go on my senior trip. Um, it happens. We see that. We get it. You know what I mean? But that goes along with that stigma portion. Mental health medications might interfere with you taking your youth. So there are some mental health medications that are prescribed to the youth that counteracts and interacts with their HIV medication. So we have to make sure that we kind of take different routes to ensure that there's no drug-to-drug interaction. Um, Transient youth store their belongings wherever they can. This one is a big one. You don't know how often we see where clients, youth, misplace their medication because they don't have a stable place to place them. Um, so they get lost, they get stolen. Other people that don't know what HIV medication is, they may think it's like another drug to get them high. So they steal it and take it. We run into this issue a lot as well. Sometimes we try to counteract that with storing their medication here at the office so that they can kind of have a reason to kind of come every single day and take it. Um, but again, that also goes back to transportation. Am I going to be able to physically get up there every single day to take that medication? That then creates a barrier. Achieving viral suppression. Youth, families, and friends aren't knowledgeable about what undetectable means. And this is the first time this word came up in this particular presentation. I kind of want to give you a background of what that looks like and what that means. Viral suppression and undetectable means the same thing. It is when the viral load has um, dropped so low in the bloodstream that medical science cannot see it. Doesn't mean that we are cured. It doesn't mean that you can't. It doesn't mean that you are cured. It just means that the virus is so low in your bloodstream that you can't pass it to anybody else as well. So we say undetectable. Um, so a lot of times it's hard for people to even grasp what that means and what that looks like because of all of the myths that we had to fight from back in the day in the 80s and in the 90s and the early 2000s. People in the community aren't willing to educate themselves about HIV advancements. Um, this is so true. A lot of our knowledge and information, believe it or not, comes from our home and our friends, right? Um, and because it's so close to, um, it can be dead wrong, but because it's coming from your grandmother or your mom or a friend that you trust, we take it as law. Like this is what we know, right? As opposed to going out and doing your own education or going out to talk to experts in that particular field. So we often battle that as well, which is going in and reteaching misinformation and myths that just aren't true. So that is a big barrier as it relates to viral suppression. Um, when it comes down to stigma, the community still to this day in the year of 2022 does not understand the difference between HIV and AIDS. Um, that also creates a lot of it still actually perpetuates that stigma of what AIDS looks like or what HIV looks like because we know it's not the same thing. Um, Youth forget in order to stay viral suppressed, they need to maintain their daily medication. We see this a lot too. When youth get to viral suppression, hey, the medicine, I'm undetectable. I don't need medicine no more. So we have to get them to understand that, hey, in order for you to stay undetectable, the medication still needs to be in your system. You know what I mean? And then also homelessness, not being able to keep up with their medication due to instability. That again, that goes back to not having a secure place to put it, not having not knowing where it is at every single time when it's time for you to take it, um, losing it, going without it for a couple of days because it's at Joe and Sue house, and you ain't been there in 3 days because you can't go back. It's another whole ordeal as well. So, again, we try to counteract that with keeping it here so that we know that at least it's not lost. So this next one, I'm going to kind of run through a little quick. So I just went over the HIV healthcare continuum, but I also wanted to talk about the PrEP healthcare continuum as it relates to our PrEP. And what PrEP is a daily pill that you can take once a day to ensure that you are not um, um, being infected with HIV. And that first pillar is prospective client or sexual contact. Sexual contact. So that is the first point of entry, right? A lot of times people are not getting on PrEP until they are having sex or have been scared about a possible exposure, right? So that's when we first see them and come in contact with them. The next portion would be inquiring/navigation. So we don't see them yet. They are starting having sex, or somebody or a partner have has said that they are positive, and that person needs to go and find where to get PrEP and or PEP. So they start the navigation process, which is going to go Google, going to go find a place to get tested, going to go find a place to get on PrEP. That's where we meet them at. The next pillar would be counseling. Counseling goes hand in hand with HIV testing and or screening, assessing the risk, and talking about risk reduction, as well as PrEP counseling and informing them about PrEP, what PrEP is, and how you can benefit from it. We're also going to go into linking, which is linkage to PrEP care, right? That's going to mirror linkage to HIV care, and that retention portion, which is also going to mirror that retention and engaging in HIV and HIV care as well, which is PrEP adherence, making sure they're taking their PrEP engagement, they are engaged in their health plan, and PrEP counseling to ensure that they understand the ins and outs of what PrEP is. All right. So again, so we got sexual contact. Um, people aren't knowledgeable on the risk factors of sex, unable to go to family to talk about it, and peers tend to misinform other peers about sex. That goes hand in hand with what I was talking about earlier about how we get with our friends and hear what they say and take it as law. Community does not know how to engage the youth about sex conversations. This is a big one. We've actually addressed this last year with a video called Sex Education. And it was a video that talks that pretty much gave us a curriculum on how that we can embed sex education in school and make it better, right? Uh, and I'm talking about starting out at the age of 5, 6 years old. No, we're not talking about sexual contact. We're not talking about sexual contact there. We're talking about um, don't touch my here, don't touch me here, my nose, my when to go talk to an adult, those things. We're talking about, and it starts there. It also talks about sexual identity and who you are. Not sexual identity, I'm sorry, gender identity and who you are, and things like that. And your sense of self. Once the people get a grasp and understanding of that, then you talk about sexual contact or sexual intercourse. But those first couple of curriculums need to be about who they are as a person and things like that. So the community doesn't know how to engage the youth in sex. We also talk about untreated mental health. Again, that can increase their risk because when they are in that particular moment of if they're, and so for example, if they're inside of that if they're inside of that magma state, it can kind of manic state, I'm sorry, it can kind of influence them to kind of do different things, and they're not having a control about what's taking place or what they're participating in. Youth get into survival sex. Again, it goes hand in hand with what we talked about earlier, as it relates to sexual contact.
Johnny, this is great. I just wanted to give you a heads up. It is almost 12 o'clock.
Okay.
But
so navigation and inquiring. Youth are afraid to talk with family about the engagement in sex, so they have to Google and depend on Google to kind of get the information, which we know that it can be not good as well. Talk about mental health, not allowing them to prioritize their mental health. They don't even know where to Google from and where to start at, and no access to obtain adequate information. So then we go into testing and counseling. There's barriers that happens there. But last but not least, we want to make sure they are adhering to their PrEP medication once they are prescribed PrEP to ensure that they're not catching HIV from anywhere. So and those are the tools that we can kind of have to support no new infections by the year of actually 2030. If anybody that is HIV positive achieve viral suppression, and anybody that is at risk or on PrEP, we have the tools right there to eradicate HIV. All right, so I'm going to skip past all of this and kind of go to one of the things that I wanted to talk about real quick is youth-centric interventions to kind of engage the youth in their healthcare. So what we've been doing now for the last couple of years is research studies, and they're all behavior research studies to engage the youth. It is pretty much helping them monitor how well they take their medication. It pretty much monitors how to help them with conversations about disclosure. There's a compare study that talks that's for people that are on PrEP or not taking PrEP or that are not positive. It gives them information on where to get tested, how often they should get tested, things like that in their particular area. So these are some of the tools that we're trying to use, and all of these are actually app-based. How often are the youth are in their phone or on a tablet or on a computer. So this kind of give them information and feed them information on a daily basis through their phone, so that they can kind of take advantage of their own healthcare and put it inside of their own hands. And that pretty much brings us to a close. I know I had to rush through this presentation, so I do apologize about that. But if you have any questions, this is just talking about the research studies, and I can kind of send the slide deck to you, so that you can kind of have and kind of look over it.
That'd be great.
Okay. If you have any questions, you can contact me through my email, which is j.wilson@calendarain.org. Or you can give me a call at 980-208-9446. Again, I know it was kind of rushed through at the very end. So again, feel free to shoot me an email or a text message or a call, and I can kind of answer. Or go over any lingering questions or comments that you may have. I would love to address those. So please don't hesitate to do that.
Sarah had one in the chat if you have time to answer it real quickly.
Okay.
If not, I can email it to you.
No, I can go ahead. Let me see. My chat is not up. That's a couple that adopted. Okay. All right. He needs to know. Okay, no. That was for that. From Sarah. I know a couple that adopted a little boy at the age of 3 in India who has HIV. The adoptive father is a missionary doctor. The boy is around about 12 or so, but it's very small. Delicate HIV is controlled. How likely is it that he has a weak immune system to any disease due to their HIV, or is it small or from? Okay. So if the child is, I'm coming. If the child is at the if the child is actually viral suppressed, and is taking their medication, what we know now is that anything that this child has the ability to live a normal, healthy life. So the fact that he's small and delicate could be something different that's going on with that child. It also can be their body structure and just how they are. They may have suffered from different things. There may be some things that they may have that may was happening before he was adopted that is now, or maybe take a little bit longer to be reversible. So I don't think that it's because of the HIV. I think that there are other things that may have taken place before he was adopted that may be affecting that as well. But if he's viral suppressed, his CD4 count has went up, his viral load is down, that has been maintained, then that has no bearing. Actually, depending on what medicine he's on, he may be picking up weight in the next couple of months because a lot of these medications are adding weight to individuals. So it most likely will, I'm sure it'll actually be something else other than the fact that he's positive.
Well, thank you so much. And yes, if you could send the slide deck, I will send it up in the follow-up email along with the recording and some resources that we have.
Perfect.
Thank you so much for presenting to us today.
No problem at all. And again, I'm so sorry that it was rushed. I wanted to kind of go over some other things with you guys, but I will send the slide deck over. I have another call to actually get on. So I'll send it over at approximately about 2 o'clock.
Perfect.
Okay. All right.
Thank you so
much.
And thank you everyone for joining. And we hope to see you at one of our next webinars. So have a good rest of your day.
Thank you. Bless everyone. Thank you.